Okay. So we're probably going to get you away at least 15, maybe half an hour early, which I think people will be relieved because it's been a long 2 days. There have been a lot of disappointed people wanting to have heard more about the data session when they weren't in the data session. Each of these sessions was filmed and will be put online on the MS Academy website. So if you really are interested in seeing the data discussion, etc., you can log in and see it online. So the next, one of the missions of this meeting is to share best practice. And we were thrilled because we got about 40 posters. Was it 40 posters? 41 posters we had. And so we want, and we're hoping this is going to happen next year, and we're going to get 100 posters. But it's all about sharing best practice. And so thank you all for going and reading the posters and voting. And so we're going to get 2 presenters up now to present. They've got about 10 to 15 minutes for each one. We're going to have discussion as well because we've created some time. So Olivia's going to come up, Masuela's going to come up first and present her work. And then afterwards we will let the poll go live so you can vote for the winner.
I'm Olivia Masuela. I am a neuropharmacist at the Oxford University Hospitals NHS Trust. So the work I'm going to present is infectious complications of high-efficacy therapies in MS. And this is about pre-treatment screening and risk mitigation. Just to give you a bit of background, as we are all aware, there is no gold standard for infection screening or risk mitigation prior to initiating DMTs. In most cases, we look at the SPCs for recommendations, and we know that these recommendations are based on clinical trial results and also post-marketing pharmacovigilance reports. The limitation with clinical trials is that it often involves a finite number of patients, and the clinical trials usually run for about 24 months, more or less. And quite often, patients with known risk factors are excluded from participating. The SPCs also often sometimes miss out class effects that have been experienced in other disease areas. In the real world, some of the adverse effects happen when more and more patients get exposed to the drug. So as an example, we looked at alemtuzumab and CMV infection. I don't know how many people were aware that the SPC for alemtuzumab got changed towards the end of 2018 to just highlight the risk of CMV and to recommend that maybe we should consider screening for CMV prior to starting therapy, obviously based on local protocols. And also, this is a growing area of interest, and this is an example in the literature, and that's an example from the paper by Epstein and colleagues. And we know that the European infectious diseases consultants put out a consensus document on safety of targeted biological therapies. So this is not only a problem in MS, it's a problem in other disease areas. They looked at CD19, CD20s, and anti-CD52. So in our trust, we set out to just set our own standards. We worked with infectious diseases colleagues, and this is what was recommended to screen for hepatitis B virus, but serology, but to make sure that the core antibody is excluded to pick out people with previous infections. We also screen hepatitis C, VZV, IgG, and HIV, HSV, CMV, and TB. So we just screen for all of them for second-line therapy. We know the recommendations are based on predicted risk factors, and this is based on mechanism of actions of DMTs. But we acknowledge that not all of the high-efficacy DMTs will carry the same risk for the above-mentioned infections. But we believe that standardized tests will make it more consistent, make sure that patients are more consistently screened, and also screening for multiple infection risks, regardless of plain treatment, aids decision-making when switching treatment. I think it also means that if you see a patient and you decide that they're going to go on high-efficacy treatment, screen for the whole panel, and then when they come back with a decision, you can start treatment quicker. Also, with starting to use ocrelizumab, patients will potentially be on it long-term and be immunosuppressed long-term, and therefore we make sure that immunization records are complete. We routinely give pneumococcus and Hib vaccine. And then for people with no incomplete immunization records, if we don't know whether they've had MMR, we would check for MMR IgG. We check for VZV IgG. And then also, if they haven't had their DTP and MenACY, we make sure they get the vaccine first. So I did this as part of my MS Academy course. So we did an audit of baseline infection screening prior to starting the high-efficacy treatment. It was to determine compliance with local standards. So we looked at which was January 2014 to November 2018, against from December 2018 to April 2019. We excluded patients who initiated treatment during clinical trials, and also patients who initiated treatment from another trust, and those who had incomplete records. So in total, we looked at 83 records. And this is what came out. So all the red bits are from before, and the blue is after. And the red, there's less screening. We weren't doing any, and that's not because we weren't doing what we were set out to do. It's only because that we were screening against the SPC recommendation, and we hardly did any HSV or CMV at the time, and TB and spot screening was a lot lower too. Also, looking at the records, on two occasions, we didn't have any records available, so we did MMRI IgG screening to just make sure that people had been immunized. And in terms of infections, positive infection serology that we picked up, there was latent TB on 2 occasions, in which case isoniazid patients were treated with isoniazid prior to starting treatment. And then we also picked out some HSV and CMV infections. Our infectious diseases colleagues do not recommend primary prophylaxis for those patients, but they say that we should be aware of a risk of reactivation, and I suppose make patients aware, GPs aware, and patients should be promptly treated if symptoms develop, and if they did, then maybe consider secondary prophylaxis. And then there was just one case where we had multiple positive viral screening tests, but that patient had IVIG infusion, so we thought that it was likely that some of it was donated from the IVIG. And then what next? We think that as an MS community, we should collaborate with other specialty to just better manage the risk of infection for people who are on high-efficacy disease-modifying therapy. And this is not only a problem for MS, it's a problem for other disease areas like rheumatology. And then for MS, it'd be good if nationally we could develop a toolkit for managing infection risks associated with MS DMTs and maybe have a consensus statement. And thank you to the MS team. There are 2 members of the MS team here today, Chris Rigosi and Gabe DeLuca. Thank you.
Any questions for Olivia? How many people in the audience are screening for MMR? Should all patients with MS be screened and immunized at diagnosis to avoid high-efficacy treatment delays? That's a reasonable one.
Yes, it's a reasonable one, and that's what we find that there's a little bit of a delay when you decide on treatment and then start looking at the vaccine status. So we think that what we should be doing right at the beginning when we're discussing treatment, then look at immunization status and make sure that everybody is up to date. And it's not only just for the high efficacy treatment, it's something that we should be doing for other therapies as well.
So that is a change in practice. Who does your immunizations? Do you do yourself? Or
so currently we get the GPs to do it. But we are also looking at speaking with public health and then getting formulary applications within our trust to just have that ability to do it, especially when people need to go on treatment quite quickly, because quite often people have to wait for appointments, and that can take a while.
Your seroprevalence of HSV is very low. Is that HSV1? So you only have 4 out of 48 or something. That seems extremely low.
So that would be out of... It should be out of 18. Yeah.
Yeah, I mean, it should be higher. It should be about 30-something%, isn't it? Yeah.
Yeah.
So I mean, this is actually a big issue now, MMR, because we now have vaccination rates in this country that are dropping to low 90s, and there's an epidemic going on. It's a real issue having one of our patients on, say, natalizumab getting measles, because they're not protected by herd immunity anymore, and so you know, we've been discussing this, and it's kind of on our list to activate in our centre to screen everybody before putting them on a therapy for MMR, because of the high risk of them acquiring infection from the epidemic that's going on. You don't want to get measles on any of our drugs, full stop. So, you know, we should see, does it make sense to screen for MMR and vaccinate? Does anybody disagree with that? So maybe we should do something. I mean, Saul's producer, where's Saul? At the back there. He's doing a paper on this, and so hopefully it'll come out in the next 6 to 8 weeks. We are going to recommend MMR screening, aren't we, in the paper? Any other questions? Issues of travel abroad. Obvious, avoid yellow fever. Worldwide issues of malaria exposures. What do you do about yellow fever vaccination?
So we haven't looked at yellow fever, and then you're right. I think that after people have started DMTs, especially things like ocrelizumab, it's not advisable to give yellow fever because it's a live vaccine.
Yeah.
But maybe I think looking at the national work, this should one of the things that we should consider. Do we ask people about where they wish to travel and get the vaccines, and what are they?
So if the Genzyme people close their ears, I've had 2 patients that we've given the yellow fever vaccine to. Both were going to Ecuador. They were going to the Galapagos Islands, and they both had yellow fever vaccines after they had reconstituted immune systems, and they were fine. But there's another reason for not giving yellow fever, is that it's potentially a trigger of MS relapses. So, I mean, there's been a small paper from Argentina suggesting that. I don't think the quality of that paper is very good, but it's an issue. Any other questions around this de-risking? It's a really important topic. Thank you very much.
Thank you.
So next is Mavis Eyre from Southampton, who's going to show us how she's revolutionized their service with an app.
Thank you to the Academy and to the Steering Committee for organising this meeting and for this opportunity as well to share my medical record. Has anyone heard of my medical record? Well done, well done. Not you, Ola. So it's been around for a number of years, actually, and the impetus for this platform was actually from Movember. in 2014, and they invited the patients to, and they asked them, what do you want from this big pot of money? And there are two things they wanted, and that was to gain access to their medical records and to be able to monitor their own blood, so PSA. Fast forward last year, so we have launched 5 neuro long-term conditions in Southampton, so MS, MND, Huntington's, epilepsy, and they've chosen MS to launch first because we are the biggest in that 5 specialties. And we worked alongside the IT team, NIHR. Our champion is Dr. Chris Kipps, our neurologist. And basically, we just, there's a platform there already. We just adapted it to MS. So our patients can download this My Medical Record app onto their tablets, phone, and desktop, and they have access to all their clinic letters, all their future appointments. As you can imagine, that has not diminished, but reduced a lot of our admin questions or phone calls from patients. They have access to the MS team, so they can message us. And when we answer their queries, we click a button, and that email thread automatically goes into their medical record. So if I'm not there, any of my team can actually see that, oh, Mavis has answered that question. So the biggest thing, we did a focus group beginning of the year and a survey, and the top 2 things that patients basically access the most is their appointments and their results. So they have access to all their blood results done in Southampton, and I've been told before the end of the year they'll have access to download their MRI scans. They have access to an information page, and the information page basically gives them a direct link to all the charities, so MS Trust, MS Society, Shift MS, Symptom Management, CAB Advisor, what services we offer in the hospital. And there's also a clinical trials page. What are the clinical trials we're doing at the moment, sort of both from Southampton, and there's a link as well if there's any clinical trials sort of happening nationally. The questionnaires, diaries, notes, and care plans, it's for patients to fill out. It's up to them if they want to share it with us. My medical record is linked with another trust, Solent, and they are basically our community neuro rehab team, so the physios and the OTs, they work with the patients to build care plans, 6 months' time, 12 months' time, I would like to achieve X, Y, and Z. And questionnaires before clinic appointments, if we as clinicians would like to send out, an EDSS or any questionnaires, we can do so, and patients will bring that in. They can share it with us, or they can just keep it for themselves. The diaries is mostly on sleep and for symptom management as well. And it just gives patients sort of a one-stop sort of app where they can self-manage as much as possible. So this is the first part of the project. We were very pragmatic when we first started this project because it's not going to be a very quick solution to all our problems all at once, and we know it's going to be a long-term project. So we have a few work streams in the next few months, and the first one is to meet with the IBS team because they are fully established in terms of using My Medical Record in their DMT monitoring. So they're quite similar to our service. They have over 1,000 patients on DMTs, and they use the platform to monitor all their patients on treatment. So I've seen their dashboard, and it's automatic. So who's due bloods, who needs a reminder. So it's not color-coded. I wanted color-coded, but apparently that's a lot of IT steps. So it's about not reinventing the wheel and just adapting it to your service. So we're meeting with the IBS team in the next few months just to see what we can adapt from their platform. The next part of the service is because we're about to reach another milestone, we now have about almost 400 patients registered on My Medical Record, MS patients. We did a really a quick survey in the beginning and invited patients and focus groups. So that's the next step, to do another survey and how we're doing. This is the first in MS, and we want to learn from it and to get feedback from our patients on how we can improve it, because it's their patient handheld record and they have control over it. And in terms of limitations, this platform is only available in 3 trusts that we cover. So Southampton is quite a big MS centre. So it's only available in Southampton, Solent, and Basingstoke, and we cover 5 more district hospitals. There are plans in place to expand my medical record to 22 other hospitals. So it's a work in progress. So listening to David earlier about dashboards, I've been asked very recently to draw my ideal MS dashboard as a service. So it's a wish list more than anything, but I've given it to our IT team, and so a service dashboard and a patient dashboard. So if I click a patient, it will tell me about lifelines, very similar to IMED, and also in terms of the service dashboard, to map out Wessex MS service and how we can have patches. And eventually, in 2 years' time, we're hoping that it will be hopefully fit for purpose, not just around treatment, but also comorbidities, lifestyle well-being, who's smoking, where do we need to focus our strengths. And the IBS team, because they've been using it for 2 years now, they've managed to reduce their outpatient clinic, and it's more of a reactive service rather than just having that hamster wheel of reviewing patients every year when patients actually don't need to be reviewed every year. And you see the patients when they need you. So either they're having problems with their symptom management or relapses, then you can see them sooner rather than later and wait for the next appointment, which might not be in a few months' time. So this is actually a list of hospitals that I've been given that my medical record is already live in the UK. So I'm not quite sure if any of you are in that sort of list. And it's an independent platform. So it's not part of the big EPR platforms in the UK. It's totally independent. The intellectual property of my medical record belongs to Southampton, and they can integrate it to any EPR in the country. And I've asked the question, who do they need? You guys, if you want to have my medical record in your hospital, you just need to contact my medical record, email them, set up a meeting. Obviously, you need to know who your IT people are and your business managers, because there's a cost attached to the platform. There's a website about my medical record. You can watch videos on how it's worked very well, especially in prostate cancer care. But yeah, and attending the meetings this morning around audit and data and how this platform can actually help us with that. So it would be quite good to, it's an exciting project. So thank you. This is underneath our poster, so if you want more information, I left it underneath our poster, so you can just grab it.
So we have some questions, if you don't mind.
Oh.
So the first one is, how has my medical record changed your work practice?
So we don't allow our patients to email us anymore, so everything goes through my medical record. So in terms of continuity of information, we can also message our patients. So that is one of the biggest things, is about communicating with our patients. And because they have access to all their clinic letters, all the phone calls about, when is my clinic letter appointment, when is my next appointment, that's all available for them in that platform.
And does it automatically go into the EPR?
Yeah, so it's connected to the hospital system.
Okay.
So Southampton is quite a digitally advanced sort of system, so everything we have now digital.
Okay. Is my MR, medical record, actively linked? Yes, it is. Okay. Who keeps the information on the app updated in terms of the services you provide?
So it's the IT, if there's anything new. So one of the biggest things we've put in there is about relapses. So we put when they click relapses, there's the NHS England definition of relapses, and there's also a video done by the MS Trust. It was done by Miranda, explaining what a relapse is, very thorough. And we always say to our patients, if you think you're having a relapse, please call your MS team, and we'll call you back.
So the next question is, what proportion of your patients are offered it, or
To everyone.
so they have to have it?
It's offered to everyone. I've not encountered a patient who refused to be on it. And for the work streams, the next steps basically is to put everyone on treatment on My Medical Record, because we will be monitoring them via My Medical Record.
Okay, so what happens if you haven't got, have you had any patients who haven't had a smartphone or a tablet or a computer, access to IT essentially?
I don't think I've encountered a patient yet with no access to any of that.
Because what you're doing is you're forcing them
Yeah.
them to be on the platform, to be looked after.
Yeah, so in terms of cancer care and IBS, none of their patients start treatment unless they're on My Medical Record. And I think it's about being proactively engaging our patients from the beginning in terms of My Medical Record, and just educating not just them and the rest of the MS team as well, what benefits it will bring us years down the line.
So what was the process of this app being incorporated into the hospital services? The question is about information governance. Did you have any issues, or was that done in the background?
I think we're in a very lucky position because My Medical, I should start saying MMR, I've been told off a few times. My Medical Record has been around for a number of years, so all the governance issues, information governance, GDPR have been managed.
So I
Before we came on
assume for
board.
everybody else in the audience, because it's an NHS-derived,
It's an NHS-funded platform.
so then those issues should be all buttoned down.
Yeah, and I've asked the question, will it ever be taken away from us? And the answer is no. So.
Okay. You should ask Japanese companies about American technology. It doesn't always work. What is the cost in setting the service up? Do you have any idea how much it's going to cost for another trust to bring it up?
A lot of money.
A lot of money.
I have no idea. I have to say that is a question I've already asked our IT guy. We were texting each other because I said I would be asked that question. And he said it depends on the existing EPR in the hospital and how well they can integrate the system into that hospital.
David's got a question around that.
You'll be pleased to know it's not for you. So there are a number of trusts that you put up on there that the Walton Centre cover. So I just wondered if any of the Walton Centre staff had come across this in any of the peripheral hospitals, Aintree, Cancer Chester, Royal Liverpool, etc. There's a few shaking of heads there.
No. Okay. Is it similar to Patient Knows Best record?
Is it?
So Patient Knows Best is a similar platform, and Care Information Exchange is based on the Patient Knows Best platform in North West London. So in North West London there is already a similar system which, if any trusts are in North West London, they can access that does the same thing.
That's not owned by the NHS, though. Is it owned by the NHS? Okay. So it
So
is.
does it have connections to medical records, messaging the team? Yeah, okay.
Any other questions from the floor? Peter Bricks.
Do you have any data on the uptake? I mean, how many patients are regularly accessing it? Because you can see we all download apps, and then often I forget I've got them on my phone.
So we get given a report every month,
Yeah.
so how many patients are registered each month and how many patients are accessing the system. So as of the end of June, we have 328 patients registered. About 216 patients have visited the site in the last 6 months. And in terms of messaging, each month there's about 11 to 23 patients accessing it every month. So we get reports, and our biggest champions are actually not the young generation of patients. So we were quite surprised when we did this first survey. It's demographics is between 45 to 55-year-olds who are sort of championing the platform.
So they're asking about the response and the notifications to you. How do you know when somebody's put in a...
So that's one of the questions in the beginning. How would we know for sure that that question is from the patient? So it's part of the GDPR process when this was launched. So they can actually share their medical records with family members. So it's included in terms of the governance of it. So a relative can actually ask us that question as long as they say that they are a relative of X, Y, and Z.
Okay, so that means other people can use the portal. Any other questions? Charmaine, no question? Okay, thank you very much.
Thank you.
So are you all logged on to Slido? Because we'd like you to vote. This is the first time we've had a live vote. It's anonymous. Oh, okay. So you're already voting? I'm not voting. I can vote if there's if it's 50-50. Just another few minutes. I can still see people logging on. So what's the prize?
It will be glass awards again.
The prize will be glass award. Okay.
It'll be engraved or sent to the winner.
Does everybody want more time? Or we...
We've got 63, I think. 64.
Yeah, let's go for it. Mavis, congratulations. Okay, so that brings that to a session. So now I've got to say something, I think. What next?
So the web space,
Yes, yep. So one of the things we wanted to do is on the MS Academy website, there's a thing called the MS Forum, which is essentially a private chat room, and we will create themes around the work streams. Rather than have it happen outside there, I think it's a much better place to have the conversations and the sharing of items on that. So that will probably go live in about a day or two, is that correct? Which means you're going to have to register and log on to the MS Academy website and be part of the group. John, is it possible to have my introduction, just that timeline slide that I can talk to? So one of the criticisms we had last meeting is there wasn't enough time for discussion. That was, there was too many talks, and the speakers didn't stick to time, and so there was very little questions and discussion. So this, I don't want to say too much. I'd rather people ask questions or bring up issues if they are during the session. I'm just waiting for that timeline to come up. Okay, so to go through the agenda again. Okay. I started off by setting the priorities and just focusing on a very difficult target, brain health, in terms of just to get us to think down the road rather than just up front. And then I think we had an excellent session from Martin Fisher and Sue Thomas, just explaining to us how we can transform MS services. And there are lots of opportunities to do this within the current working environment, but it needs us to think a little bit differently about what kind of services we had. I think the consensus, I won't say the consensus, but there was a vast majority of people felt the current paradigm that we work in is not working in terms of the perfect storm we're facing. So where's my perfect storm slide? I think you've seen it a few times. This one. It's the other one. Oh, it's the other one.
this one. So in terms of this, it's just, I think we've all got to come to the realization that we cannot continue the way we're working. We'll all be burnt out, retiring early, and that's kind of what, you can't pick up a newspaper or the BMJ or anything like that without reading about all the consultants retiring early. And they're beginning to blame the pension on that. I think it's not the pension, I think it's the burnout, not the pension scheme. So we can't continue like this. So this is why we really do have to engage with things like we're trying to do here, is how do we reconfigure and change the way we practice. Get rid of the Victorian model of medicine and introduce a new model of medicine. And I think Jerry's presentation yesterday to try and stimulate us to think about the why, okay, and the how and the what, and why we're doing it. So please go away and think about that. And then Alison's talk to me was quite inspiring in the sense that we are not tapping into the potential of using the people with the disease as partners in terms of helping us transform these services. And I think the example she gave, and I've spoken to many times about those examples, although they come from mainly the primary care environment, they should be applicable to the secondary and tertiary care environment, unless you disagree. But it means taking time out of our busy busy weeks to make the effort to set up those, what did we call them in our session? Meetups. Set up the meetups to do that. And then I think Carolyn White put us back in our place last night because she, as I said this morning, this is a highly educated, she's an empowered woman who I think the system probably let her down. And if it lets people like Caroline White down, it's got to be letting everybody down beneath her. So it's, there's hierarchy of beneath her being let down by the services we provide. Gabby and Barbara also inspired me. I mean, I've heard Gabby talk quite a few times and every time he makes it more inspiring than the last, about why leadership's really, really important. And I've already had about 4 or 5 people ask me, could they apply for the leadership? And I think I'd urge you all, if you really want to get leadership skills and make a difference, then apply. I don't know what the criteria are, but I suppose it's going to be very selective first time round, just so that they can make it a success. So please put your applications in for that. Then I didn't hear David's thing, but I knew the content of that. So the data is critical. So if there's 2 things I want out of this meeting, is an audit. For a personal level, I want a national audit because we need the data to change behavior. And the second thing is local champions, people to go back to their services, back to their centers, and decide to change things. And that means collecting data, but also collecting and trying to implement some of the ideas that have been discussed here to change the way we practice. And then to bring back best practice so we can share it. This is what the MS Academy platform is for, sharing best practice. And then Rob gave us a thing about, his session was about, I was in that session as patient and partner. And that's very, very exciting because this is an opportunity to co-design with our patients services that are configured to their needs and to make them partners in it and to get them to self-manage and self-monitor and do everything we want them to do and make our lives easier. This is why this award for the best poster is so relevant, because that's exactly what we're doing, what that app is doing. It's actually making patients partners in their self-management of their disease. So there are changes happening in this area. Then Jeremy's session is really where we're going to be judged. This initiative is going to be judged next year about how far we are with the pilot audit. Pressure's on you, David, and Jeremy, to make it happen. Then the social determinants of health and the wellness and lifestyle interventions, we poo-poo these things. In a sense, they get dropped down the list because they're not up there, but they are probably at a person with a disease are critically important. If we do want to use marginal gains and improve everybody's quality of life and outcomes, we cannot ignore lifestyle wellness and the social determinants of health. And how we embed that in our services is a real challenge. I actually had a discussion with our manager before last. We get them so frequently in our centre, it's unbelievable. Our business managers change regularly every 12 or 18 months. So I think three managers ago, I asked them if we could put a wellness program in. They just laughed at me. I mean, they were worried about breaches and waiting lists and putting out other fires. You know, talk about wellness is difficult. So that's going to be a real creative solution. Is how do we incorporate? Somehow it seems to happen much easier outside of London. But that's just my imagination. So those work streams are going to have to be quite creative about how we liberate resources or generate business cases for new resources, or do it with different types of practice and incorporating ours. And that's it. So we're going to come back next year. Wrong one again. We're going to come back next year, having moved up from 2 bronzes to 7 golds. How's that sound? And I'll go to this slide. So I just put this up as 1 year's time we need a pilot quality audit. Jeremy, how many centers do you want to participate?
71.
That's quite a lot.
Yeah.
Are you wanting to put that as a target?
It's ambitious.
Well, I think everybody can contribute to it.
Okay.
That's the point.
So if anybody's come here, you've really committed yourself to the audit. I probably will allow
Fall out of work.
So maybe we should say, you know, a success next year this time is an audit of 50 centres with the pilot. Does that sound reasonable?
That's very reasonable. Yeah.
The other thing we haven't got, and it's very difficult to obtain, is a database of all the prescribing, all the MS centres in the country. With the new European Data Protection Act, everybody's destroyed their databases. Most people's databases aren't up to date, so we do need word of mouth and to try and get our database up to date. So please, if you know anybody who's been left out, let us know so we can invite them and include them. Rob, we did set the Shift MS team something by 2021 in terms of a patient partner program. Now, I don't know what that's going to look like, so it's difficult to be confident, but we need to come back a year after having done something in that space as well. So in other words, how do we reconfigure our services that are not follow-up driven but demand driven, and how do we incorporate patients as partners into our practice? And then the no patient left behind, so that would be the wellness, lifestyle, social determinants of health. We can have those incorporated routinely into our services, and that will be July 2020, so that's 3 years down the line. Okay, do you think these are too ambitious, people? Because I just put these together I put these together a few weeks ago in the document. So ask people questions. Antonia, do you think this is too ambitious? Is there anything we've left out? God, everybody wants to go home. Okay, I think everybody wants to go home. Yep. So the next thing is valuation forms. Could you please fill them in? Because we would like to, if we can, have this meeting again next year. Probably in a similar venue, because Birmingham seems to be a place where people can get to in terms of being a hub. And then we also want suggestions. So part of this is CME, in other words, continuing medical education and professional development. And so please put down topics that you want covered. I already had a suggestion by Gabby about including cognitive biases and how it affects our practice into the next one. Oh, something on avoiding burnout and resilience. Okay. Shamoon? What? Employment. Okay. All right. So then I would just like to complete the thank yous again. So without Sarah and her team at the Neurology Academy, this wouldn't have happened. So a round of applause to them. To our sponsors, so that goes to Roche, Biogen, Novartis, Merck, Sanofi, Genzyme. Thank you very much, and I hope you continue to support this. Thank you. To all the speakers and the workstream leads, and to everybody who came, thank you very much, and I hope you enjoyed yourself. And you can go, it's half an hour early.